I'd like you to start by taking us into your present-day reality. What's important to you right now, this week, this month? What's causing you to lose sleep at night, if there is anything?
Yeah, so, adults with congenital heart disease who I care for have been oftentimes in the healthcare system for a really long time. And what's happening now is we find that we think we fix them when they're younger, but we haven't. There are progressive things that happen. And so on a regular basis, it's making sure that people stay in care, even though they're feeling well, that they understand that now with technology, we can catch things for them before they actually happen. And then the hardest part of that is teaching them to live with that without being anxious, without the PTSD of what happened when I was a child coming back, without that feeling of any day now the other shoe's going to drop. So really helping them feel empowered about their disease and yet recognize that it needs to be followed. And I think grappling with that is really probably daily the thing that keeps me up the most.
I recall from our earlier conversation that you got interested in this patient population very early in your medical training. Can you tell us a little bit about that?
I did. It's funny, over the years, your image of something changes. So it may not be exactly the way I picture it now, but I was at Yale for medical school. I had done a rotation in pediatric cardiac surgery, and I had loved it, except the hours were, 4 a.m. to midnight. And you got all the glory, but then you never got to follow the patient longitudinally. They were somebody else's. So next I went to pediatric cardiology, and I enjoyed that, but one day we got called to the adult cardiology floor. And if you know the adult cardiologists at Yale, who I love, they don't call people for help very often, do it ourselves kind of group. And they called, and they said, we need the pediatric cardiology team here. And it was a 44-year-old with a disease called tetralogy of Fallot, who had been a blue baby, had several surgeries, who was having an arrhythmia, and they said, we don't do this. We don't know what to do. So, our perfect V-shaped white coats flying in the back formation of pediatric cardiologists, we arrived on the scene and helped explain what we thought was happening. But that, I think, was probably the day where I thought, this is a niche that's going to grow, and it's a place where I think I could belong.
One of the things I really emphasize in my teaching in business school with MBAs is that innovation, everybody thinks it begins with an idea, when in fact it begins with a person, a customer, a patient in your case, with some needs that haven't been met. And this is a population that has had a lot of needs. Can you talk a little bit about how you view that?
Yeah, this is a population who we didn't know was going to exist. And so you have, adults who go to adult doctors, and the adult doctors say, well, you're not an 80-year-old with a heart attack. Or you have adults who go to a pediatric hospital and they sit in a pediatric waiting room with 7-year-olds, and that maybe frightens the 7-year-old and the 7-year-old's mother more than it does the adult. What's going on here? And so they clearly, even in the beginning, had an unmet need, which was a caregiver population who knew both medicine and pediatrics and could care for them. We thought that that was all they needed. And we get back to this a lot, which is the whole idea of why we needed to build a team, which is they don't just need us to care for them in that way. They need us to understand what they've been through. They need us to help them through things like pregnancy, which they didn't know would ever be possible. Their parents never told them. We need to help them run the 5K or the 10K or the half marathon, despite the fact that they have heart disease, because that's who they feel they are. So the rest of life has to happen. And for now, I think that's our biggest unmet need, is how do we help them engage in the rest of life and know that they can do that. And so that's the area where we're really trying to grow now.
I imagine that, though it's a small population, there's probably a diversity of personalities in it, and needs and lifestyles and goals. Can you talk a little bit about how you or your team tries to match your approach to the individual patient?
Absolutely. So there are people who lived despite their disease, whose families encouraged them, who, played t-ball and then played baseball and then were in the winning Little League team of 1984. And then there are those whose parents said, we have an excuse for gym every year. and our child does not participate. And those two patients, who are actually two patients of mine, had the exact same disease with the exact same surgery. So there is so much about how you are raised, both who you are and what the environment around you was. And so when people first come in, the first thing we do is listen. Our first appointment, we rarely make any big clinical decisions. We just sit down and get to know who that person is and who is involved in their life, who shaped them, how have they gotten here. Because if you don't understand that, it's actually very hard to provide the right clinical care and the right direction, and it's especially hard to keep people in care. If these young individuals don't connect with you, they're not interested in staying in care. As it is, you know, they have lead feet coming back into a hospital where so much of their life might have been spent. There's another population. We have gotten so good at technology that now people in midlife and later adulthood are diagnosed for the first time with congenital heart disease. That's a very different customer population. That's a, how could I possibly have had this my whole life and I didn't know? That can be a little bit of an angry, I can't believe no one has found it until now. And the truth is, it probably wasn't affecting them significantly. Maybe it was and it was silent. Maybe we lived in denial, or maybe because it's so rare, people didn't pick up on it, because if you're not a specialist, you may miss it and not catch it until it declares itself. So a lot of different approaches, and again, that first appointment is listening. It's what you teach about. Learn your customer base. Walk their walk, see what it's about, follow their journey, and then understand how we can help.
I was really intrigued by the sharp distinction you described between two patients with the same disease. One was given an excuse for gym, the other was very athletic, for example. Can you tell me just a little bit more about how the care differs for those two patients once you've sort of diagnosed that they have very different upbringings?
So part of our goal is to individualize our approach, but start with a standard that we consider a high and a level standard for everybody. So we're going to try and get everybody to the same place medically in a way that they need to get there. So if you take the person who hasn't been encouraged to exercise, that's where we found we actually needed nutritionists. I think my family would laugh. I probably am not the best person to give nutrition advice. You know, don't do what I do, not what I say, or do what I say, not what I do. So when you first meet these individuals, I think what people want to hear is that it's not your fault that you are overweight and sedentary right now. It is a lifestyle, and a lifestyle change, as we all know, is one of the hardest things to do. So we found that we needed a nutritionist to actually help people understand, how do I change my life to have nutrition that will benefit me? We had exercise physiologists actually give patients prescriptions, and that prescription may be walk for 20 minutes twice a week. When you get that down, get to 30 minutes 3 times a week. When you get that down, get to 40 minutes 4 times a week. And so we push them in a way that fits with themselves. For the Little League player, it's, yes, go ahead, keep being active, but you know what? That valve looks like it might give you symptoms. So I'm going to put you on a stress test, not a regular older person stress test. I'm going to really push you. We're fortunate to have a performance lab here, a cardiac performance lab, and we really have them push our athletes to their max. And we say, at your max, how do you feel? What happens? And so that's where it's hard for those individuals sometimes to say, do I choose to do less than my max so my valve doesn't need to be replaced yet, for example? Or do I want to keep living at my maximum, and you know what, let's go ahead and do this surgery? And so there's a lot of shared decision making in what's the right choice for each individual. But again, there are guidelines for the care of these individuals. So even though it's individualized care, just because you were more or less active doesn't mean eventually we won't get you to the same place that you need to be.
One of the things I learned when we spoke earlier is that a lot of patients are sort of lost to follow-up as they transition from the pediatric system to the adult system. What are the causes and consequences of that reality that you've contended with?
Yeah. So we in pediatric cardiology, period, in the 1970s and 80s, are probably the number one reason these people are lost to follow-up. We thought people were fixed. There are families who come back and say, but you told us we were fixed, you meaning the profession. And so the phrase we use now is repaired, not cured. And so we start at a very young age now telling people, you will be in lifelong care. When you're done in pediatrics, you will go to adult congenital heart disease. We didn't do that for probably 2 decades or so. So those individuals left. I think the other reasons are ones that are life reasons. We go to college or we get a job out of school. We have a child, now we have 2 jobs to try and maintain that child's education. You're just too busy. And so if you really look at even the average 20, 30, 40-year-old in the United States, many aren't seeing their primary care as often as they should be. The same is true for the congenital heart disease population. And so really making people understand that we're just going to check in on you. You need to come back to care is important. It's hard. We take care of people who live 4 hours away. And, I get stuck in 30 minutes of Fenway traffic in Boston, and, I'm upset in the car. So imagine 4 hours, to get into the city, to have someone tell you you look good this year. So we've actually started using telemedicine for some of these folks. Get a local doc who'll talk with me. We'll use telemedicine, and then once in a while when you need something that we can provide, you come in, you get all your testing done in a day, and you go back. We just need to give people ways to get back into care.
I was surprised, and of course I shouldn't have been surprised when talking to you the first time, that PTSD is something that you deal with, and especially for patients as they come back to the hospital, even for a routine appointment. Can you tell us just a little bit more about that and how you deal with it?
Yeah, there are a lot of people who will very openly say, I don't want to come back. There are many more who come to the office, and we call this thing white coat hypertension. Refer to it with all different people. When you come to the doctor, your blood pressure's higher. Note to self, I don't really believe in that, because that means, when your kid's not getting ready in the morning, your blood pressure's higher. When your spouse and you are arguing, your blood pressure's higher. So you probably have hypertension other times. But we see that individuals who can't engage with you in conversation probably don't learn as much or share as much about themselves. And so anxiety when you're in the office is actually not productive to the health relationship between the physician and the patient, or the nurse and the patient. And so we've actually, done some studies now looking at if you can help people relax and be calmer in their appointments, they do better. We found one of the best ways to have them relax was to actually not bring them into Boston. This is not a reflection on the traffic, although maybe. But we have a Waltham office, which is a town that's, just a couple towns over from Boston, right off the highway, easy parking, no traffic, no payment for parking. People there, boy, do they engage. The same person walks in with a big smile on their face, and they spend 1 to 2 hours listening, learning, talking, without the anxiety that we sometimes see here. So sometimes it really requires an infrastructure, a physical change that actually makes the rest of it come much easier.
And what you're saying suggests that an online appointment with your doctor might be even better sitting on your couch at home.
People are so much happier on their couch at home. Also, if I'm 10 minutes late and they're on their couch at home, they're not unhappy with me. In the office, they're not completely thrilled. So I say 10 gently, maybe 20. But no, it's nice, and it's also nice because if you just think about that one individual, it's hard for them to get in. But think about them and then getting their spouse in, or their parent in, or their children in as they get older. It's actually hard. We have a couple of patients who, have a lot of dogs, live up in Maine. We have a family out in Western Mass who owns horses, and they say we actually can't leave the animals for that long to come and do all the stuff. And so for them, it's great. We joke, sometimes we let the dogs in on the visit, but people are so relaxed in their environment, and then we connect. In fact, we probably connect a little faster sometimes over the video than we do in the office, where everybody's used to the preliminary niceties.
Yes. I wanted to ask you about one other sort of subpopulation, and that is mothers who are expecting.
Yeah.
I know that you mentioned patients with congenital heart disease are often concerned about passing on their genes to their offspring.
Yeah.
Tell us a little bit more about the needs of that population in particular.
So there are people that don't even realize that they could become pregnant or carry a child. So that's the first conversation, is again listening and saying, have you thought about family? There are many who actually don't want family as well, and so then you don't want to make a judgment or force something on them. And so the first is to listen and see where they're headed. Once people say, yes, I think I would like to bear my own children, where do we go from here? Part of it is making sure they're safe. So heart muscle is safe, valves are safe. They're not still blue adults like they were blue babies. Some of those things we need to make sure are in check, and so there's generally some imaging involved. And then we actually found that having the geneticists work with us and the genetic counselors has been very helpful. We will broach the conversation first with the fact that the risk of transmission is actually pretty low if you're the only one in your family with congenital heart disease. If you have a grandma and an aunt and then there's you and a cousin, now that's very different, and genetics hopefully is already involved in your care. But we'll start that conversation, and again, the genetic counseling piece sometimes is just a one-time conversation. Other times becomes more necessary throughout pregnancy. And we've done it using the telemedicine as well. The genetic counselors actually really love it because it lets patients be comfortable and really listen and engage in these conversations. So people have done very well, though. We have, I don't know if you can see behind me, but there's a baby wall back there as well, some athletic teams. And so people will send the pictures of their kids, and everybody's been really happy with the process, I think. But it took time to get there, to recognize, and this is one of the big things, to recognize that something that used to be done as really solo medical care. My predecessor used to just do all this himself, the counseling and talking to patients, and I still launch into it. But I realize that there are people here who actually do that one part for a living. And when you introduce them to this population of unique patients, they love it. They get involved, and many of them say, this is one of the best parts of my job because this is a population who wants to be out there, be active, as normal as they can, and we can help them do it.
So we have spent a good chunk of time now just getting to know the population, and I think that's an important thing to do since it's unfamiliar to so many, certainly to me before I got to know you, and to probably to most of our listeners today as well. But let's transition now and talk about what you saw when you were being mentored at Mass General by somebody who did it all himself, and sort of what you learned along the way that made you see, my gosh, it'd be so much better, or it would be better if we could have a whole team of specialists that were focused on this conversation, or on this population, excuse me.
So you can see right now I sit in, an office in a clinic building with other cardiologists. When I joined here first, he was actually based out of a 2-bedroom apartment, adjacent to the hospital, but not in the hospital. And so that's where I first practiced. It was a warm place. We had a waiting room that was essentially a living room. We could not nearly fit everyone in there, so people would line the hallway of the, first floor of the apartment building, and everyone knew, oh, you're here to see the docs, okay. That warmth, I think, is something that we have worked very hard to carry forward into the clinic arena. And I am so grateful to have been first inculcated into the practice of medicine via that mechanism, because that's what people come for. They come for the connection, they come for the trust, and then they come for your academic knowledge and ability to care for their heart. The part that I found was that there were a lot of unmet needs for this population, and some of them we talked about. So PTSD, how good are we at actually treating that when there's a whole discipline for it? Anxiety, depression, even things like being athletic. I could give them rough guidelines, but there's an entire performance lab who knows how to give them full Division I athlete guidelines. And so that was when we realized that if we really want to affect these individuals' lives, not just their heart, we need to tap on all of the resources that we have. And many of them, like you say, are not these high-tech things that we can do, although we use all of those in caring for these patients. They're the simple connecting you to a person who can talk to you about nutrition in a way that they do day in and day out. And that was when I realized that what we were trying to do as individuals could probably be done better with a team of people. Now, the key thing about a team is we didn't just say go to a nutritionist. We went out and we found a nutritionist who we liked, who saw a few of our patients, who they responded well to. And then we essentially said, hey, guess what? You are the new nutritionist for adults with congenital heart disease. And we brought them into our family. And that family has grown. We have many caregivers who work with us now. And even though I may not see them on a daily basis, I can tell you that Dr. Karen Anderson is the liver doctor for adult congenital heart disease patients at Mass General. And she herself will now say, yes, I am. And then she'll laugh and say, I'm not sure how she roped me into this, but, you know, we went to med school together. I called in a favor. I liked her. She liked this patient population. And so now they mini-specialize in this patient population, and that's how we've kind of carefully grown to get the right people for our team.
You know, what I heard as you described that is your real starting point was humility. It was a recognition that you didn't have all the answers, or that there were other clinicians that could bring something to the team that even better than you yourself could provide. And that seems just worth saying, because I've seen that as a common trait amongst people doing the type of work we talk about here, a recognition that a team is stronger than an individual. You have, if I have it right, another cardiologist on your team, a nurse practitioner, a nurse, a social worker, and an administrator, just counting those working full-time. Is that correct?
That is correct.
All right. Can you tell us just a little bit more, starting with the folks that I've just listed that are full-time, about how you sort of divide the labor, what the roles of those people are on the team?
Yeah, so myself and Doreen DeFaria, who's the other cardiologist, we are the face front of the operation, if you will. So anybody comes in the office, we're in the office 5 days a week. We make sure to, you know, see people same day, the next day if they need to be seen. And we're kind of the ones who are the first introduction into the world of congenital heart disease. We would not possibly be able to do this, I think, without the teamwork. So probably the very first interaction, not the face front, but the interaction is our administrative assistant. So Linda Dell'Olio is our administrative assistant. She has years of experience working in the cancer center, working in neurology, working here. And everybody always says, well, do we get to meet Linda? In the old office, Linda was right out front. Now we're in a clinic model. There's a front desk to the clinic. Linda's back here with us. And so people will specifically walk through cubicles to go and find Linda's cubicle to talk to her. And I think it's so important that she feels that these are her patients. Similarly, our nurse and our nurse practitioner, so our nurse, Lauren, has a lot of training. So she has trained in cardiac rehab, cardiac ICU, patients who are on ventricular assist devices, very complicated. And she actually was the one who developed the Waltham office. She was the one who said, we need to take them out of here. Do you see them? We need to take them out of here, Ami. And I said, I think you're right. And we went out there, and she has her green folder. And in the green folder is nutrition advice, is exercise advice. She has self-taught how to do mini relaxations in the office with patients who she thinks are just too anxious to engage at all. And she will do it with them in the office, and they'll kind of relax together, and then they'll embark on the visit. Our nurse practitioner, actually, we just lost since the last time we talked. She was fresh out of nurse practitioner school. Learned the field, loved it, and for family reasons has moved to UCSF, University of California, San Francisco, where she is doing congenital heart disease, because we did at least build in her a love of something. And so we are looking for somebody new to replace them. And in doing that, it's interesting. You really think about what is that person's role? How will they fit with the family? And it's interesting how you say this thing about humility, but it kind of also goes to, will they be a team player? Because, again, every time we add someone new or replace someone, we really want them to consider this their home away from home, and respect the people they work with and the patients as our second family. So the logistics of how things work, there's a lot going on. When a new patient comes in, they have years of history. They have details we need from multiple hospitals. We have to get all that data, get all the imaging, upload it to the system, review it, figure out what they need, and then set them up with an appointment with us in addition to the extra testing, ideally on the same day, but do so in a response time that feels like it's within hours to a day at most. And so if you think about each new phone call, we are busy. We are consistently working to try and get those patients to come in, but to come in with the right data. I will tell you that there are gaps in the system. There are patients who say, you know what, I just need to be seen next week. And you say, we've been calling for your data. We have nothing except maybe the little folded up piece of paper that your mother keeps in her purse, and they say that's okay. So yesterday I had a new patient whose mother took out an old folded up piece of paper and said, this is what my daughter has. Her daughter is now 22. That was from, almost 20 years ago. And we worked with that in my exam of her, and we had a little handheld echo in the office that we're trialing, so we tried that. And we did the best we could, and I said, look, when I get your data, we'll televisit because you live far away, and we'll go through it all again, and I'll show you the pictures, but I think this is roughly what you have and where we're headed. Is that the perfect appointment? Probably not, but for them, they needed to be seen. And so in a way, yes, that was the perfect way to do it for now, although systematically, boy, don't I wish that we could get it all done a little bit faster.
I have what may be just a stupidly elemental question about teamwork. You all are clinicians. You all have such busy schedules. To function as a team at the most basic level, you got to talk to each other.
Yeah.
So you see a patient. Your team, your nurse sees a patient. The social worker sees a patient. How do you find time to combine all of the insights and all of the data you gather from those interactions into a complete picture of a patient and their condition and their needs?
Yeah, that's a great question. So part of it is that we're all naturally very chatty, and I've physically co-localized most of us. So there are conversations that happen back and forth in the hallway. I just saw so-and-so, they have this, the other has that. It's probably not ideal, but we do it constantly, and we usually know which patients are in-house on any given day for an appointment. So everyone pre-looks at the list of patients for the week. We each have it on our desk for the day, so we know this set of 20 patients will be seen. Everyone who's involved in their direct care will actually enter what they've done into the electronic medical record as part of one note. So some people say our notes are too long. I like to call them comprehensive. But we will enter everything we do into that one body together so that anyone else who's adding to it will see what else happened on that day. And then we actually have formal meetings. So the group we're talking about is the immediate patient comes in and gets seen group. It does not include the surgeons, the catheterizers, the arrhythmia doctors, the nurses who work with each of those groups and the nurse practitioners, separately our social worker, our genetics counselor, and then our OB group. And so all those other people are kind of our probably very important interventional layer when we need things done, our imagers. So we bring the larger group together every Monday. We get together every Monday, and from 12 to 1, we start the week together talking about the most urgent patients either of the week or things coming up or something we saw last week that we must address as a group. And so every Monday we get together and we run through a list of patients to discuss with all 22 people in the room. And then we move on from there. You once asked me, is that one meeting enough? My answer is clearly no, but I think their families would all get very mad at me if I brought them in at 6 in the morning or at 7 in the evening for a second meeting, although I am debating on it because the volume is just increasing, and we do need to be able to keep up with the group think. I think what we offer, that I think is the most valuable is this number of people all thinking about one patient at the same time, out loud in the same room. And that's another place where egos are not allowed. You check your ego at the door when you walk in, because the goal is to think out loud with one another, to disagree if we see something different respectfully, and to figure out what's really best for the patient at the end of the day.
Thanks for that. You mentioned just a few minutes ago that you're in need of a new nurse practitioner. And I'm wondering if you tell us a little bit about what you'll be looking for in a world where most people are used to working as individuals. You're bringing you will be bringing somebody into a team that operates like a team and has been operating like a team. How do you know during the recruiting process that you found somebody that will fit right in?
It's always a challenge, isn't it? So I think the first thing is how they interact with everybody just during their interview when they come in. So we have everybody interview them. There's no I just interview and decide. So the whole kind of immediate front group will speak with them. I think a large part of it is their willingness to be flexible. And so, some people like to do a certain job, and this is my job, and what's on paper is what I do. It's not how we work. How we work is this is the basics of what you'll do. You'll see patients. You'll see them in follow-up. You'll have, do the usual clinical care, check their labs, explain to them what their results are, interact with the rest of us about it. But it's also, one of our we have Linda's our main administrative assistant. We have a second person, Pam, who works with us 50% of the time. And Pam always likes to say, everybody's got to lick the stamps. And it's true. And so I think that's kind of what we look for, is somebody who says, I'm excited to work with this population. I'm excited to work with all of you. I understand my basic job principles, but I'm also willing to go out there and do different things that maybe don't sound exactly like a nurse practitioner job because it needs to get done for the team.
Fluidity and flexibility is important for any new team coming together in any enterprise because you don't know exactly what the needs are going to be, and you have to adapt. But you've been at this for several years now, and I'm wondering if you've seen sort of a trend towards people's roles becoming crisper and more defined over that time period, or if you're still very, very flexible from day to day.
Oh, this is a tricky one to answer. You know how to pitch them. No. I think we have gone through phases of trying to, on purpose, create a more defined structure, thinking that will lead to efficiency. Mm-hmm. It sometimes has led to efficiencies in small ways. The following, making the list of who the patients are, who will be interacting with them for the week, actually fell onto the nurse practitioner, which is in no way a nurse practitioner job, and yet she was good at it, she was fast at it, she used color coding that everybody liked, and it became part of what she did. That part became good. She has now left literally a week ago, and I still don't know to this moment who's going to make the list for next week, and who knows how to do it the way she did. How did she get in and out of the charts fast enough? Did she waste time doing it? Did she not? Because there are other things that need to get done. We didn't have a second level, and that's a very small example of what our daily life involves. There are hundreds of other examples of that, and so I do think that structure in some form leads to efficiency. I think there are other places where if there is structure but there is exclusive responsibility, then that becomes a problem if that one person is missing, and then you no longer have a very good team dynamic. You can't take that one cog out if you don't have a replacement cog, or if someone else can't kind of pick that up. I'll tell you a place where it worked, which is out at Waltham. We started to go as a group. We brought some fellows. We brought a nurse practitioner. We brought multiple doctors, and we ended up settling into myself and our nurse Lauren, whose idea it was to go to Waltham and start this health and wellness version of our clinic.
Yes.
And we find that the two of us together, work magically. So the patients come in, they get their EKG done. She does their general care, the health and wellness teaching, the relaxation. I come in, we talk about the hard stuff some. We review what she's talked about with them. We pick some goals for next time. We talk to their family members either at the visit or we call them in. We get them set up for their testing and they go. And we can, the phrase is probably not right, but we can crank through them. Like we know what we're doing. We're in a rhythm. We're enjoying it. The patients are getting the right care. So there are certain places where we found that efficiency really does work, and infrastructure is important. So that's really our role out there now. It does introduce the question of if we want to have more outlying clinics, who will go there, How will they do it? Will we go those places? Do we need to hire other doctors? Will they work the same way we do? Probably not, because their personalities will be a little different. They'll have to find their own way. So again, I think structure is really important. I think it can lead to efficiency, but I think the exclusivity of responsibility sometimes gets us into trouble, and so you have to balance those two things.
I think that's a great answer. One of the things you emphasized to me in our earlier conversation was that patients are on the team too, and their families and their caregivers are on the team as well. I hear comments like that a lot, and these days, and I find people mean very different things by it. And I wonder if you could talk to us a little bit about what that means to you, and in what ways are patients and their families and their caregivers on the team? What is their role?
So I think the first thing is we're all here for the patient's care, but what the patient thinks that care should be is different from individual to individual. Sometimes it's different within a family. Sometimes the patient thinks care means you need to make sure I'm okay and I never need another surgery. The mother means do the surgery as soon as you even think it might be likely because I don't want my child to get sick. And the spouse says, can you just help him be happy? Can he just live life and not obsess about this, and my mother-in-law not obsess about it? And so those are three completely different perspectives of what my job or our team's job is in care. And so the first thing, again, is listening and almost getting everyone on the same page as to, here are our goals for your card. Does this sound right? Are we on the same page? Are there things you want to concentrate on differently? And that can be at an individual appointment. What do you want to focus on today? Here's what I need to focus on. Or that can be longitudinal. I don't see you headed for a transplant, but I want you to get a heart transplant evaluation in case the following. Are you ready for that now, or are you not? It's not that short a conversation. It's a longer one, but again, it's figuring out what the patients want in their care first. And then after that, it's holding people to what they're supposed to do. If you schedule a test and 3 tests are on one day and people move things around to get the test done that day, my patients know Dr. Bhatt's staff really moved things around to get this done. I've got to show up on that day for those 3 things because that's my part of the deal. Or if I say I'm going to work on that 10 pounds of weight loss, I'm going to work on the 10 pounds of weight loss. So I think that's really important. Sorry, my computer logs on and off, so this is me typing to be able to see your face again. There we are.
No problem at all. And while you are doing that, I want to introduce Catherine Kemmel, a doctor on Long Island, a pediatrician who works with children with complex medical conditions who would like to ask a question. Catherine, go ahead. Please be sure to unmute your phone.
Hi, can you hear me?
Yes, I can.
Okay. Sorry, I know I sent in a couple questions when I registered, so I wasn't sure if this was the point in the conversation where we could start to address some of those questions, or yeah. So I have 2 questions. The first one is, do you have a transition program? I'm a pediatric pulmonologist, and in some centers that I've been at, we had a formal transition program for moving people from an adult to a pediatric center.
So,
I mean, rather from a pediatric to an adult center.
Yeah. So, yes, we do. We're lucky at Mass General that we have both the pediatric hospital and the adult hospital under one roof. And in fact, in the outpatient setting, we're 1 floor apart in the Yawkey building. I'm on the 5th floor. Pediatrics is on the 6th. And so for most patients around age 18, we start that process. And what we found, Catherine, and I'd love your input, is that you actually need to start teaching about transition much earlier, and that in fact transfer, which is them coming to me, is probably the least important part of that process. But it's the idea of, how do you take care of yourself? How do you understand your disease? Do you understand your medications? Do you know how to make an appointment or call your doctor if you needed help? Do you know, as you get older, when your insurance runs out and what you might do next? And so, you know, there are many different stages, and we have a form that we kind of use for that to see what stage different patients are at. It also helps guide us to the transfer process. There's some young individuals who aren't really ready to leave the pediatric realm until they're a bit older, 22, 24. Some of those are the syndromic or complex disease children. There are others who at age 16 are like, I'm on top of all of this. I want to take charge. Can you move me up to the adult side? And we say, you know what, you do have it. You seem to understand. So a lot of the teaching, I think, needs to still begin in the pediatric realm. I don't know if you agree or how you do it there.
I absolutely do agree. We do not have any transition programs at Stony Brook Children's where I am. And that really is just due to a current lack of adult partners. So we do work on health literacy and taking charge of kids' own health from the point where they're, teenagers onwards. And we do that pretty systematically as pediatricians, although not ideally. But we just don't have adults to partner with.
May I make a suggestion? Chris, is this okay?
Yes, please.
Okay. So one thing we found, because there have been a lot of groups that we work with who obviously are far away and are trying to find local groups, is if you do have a transition readiness checklist, if they're working through that, oftentimes singling out a few providers, whether internists or a subspecialist you're looking for in the community, and saying, would you be interested? Here's our checklist. Here's all the things we make sure they can do before they transition to you. That's helpful. And I will say, and this goes back to my thoughts about team, which have changed a lot over the past few years, if you can find a practice that not only has nurse practitioners and nurses involved, but has care coordinators, and honestly has a respect for that team dynamic, you may be more likely to find kindred spirits who are willing to start to associate and make that relationship. But there's legwork. You have to really go out there and almost meet people or have someone go out there and meet people and say, what is the right practice for us to land our patients in? But I would look for people who maybe have more of a team dynamic than a solo practitioner, and those who have physician assistants or nurse practitioners or nurses or social workers or care coordinators in their practice. They might be the right practices for you to build a relationship with. Sometimes we do something as simple as take them to a nice Italian restaurant for dinner and get to know them, and then, right as dessert comes, we're like, so, can you take some of our patients, please, and we'll show you how to do it. But it does kind of work.
Those are all great. Those are all great suggestions, and we actually do have our MedPeds program is growing a little bit, and I think they're working on some of those ideas. May I ask my second question now?
Mm-hmm.
Well, yes, we are getting towards the end of the hour, but let's try and squeeze one more in. Go ahead, Catherine.
How do you support your program, and how do you measure its value? Because it sounds like most of it is not, you have the ability to dream and to do what you think is right, but it sounds like you have some sort of private supporter that allows you to do that.
So right there, you just gave me the Italian dinner dessert punch. Okay, I felt that one. So that is the hardest part, hands down. I was ecstatic when, maybe not ecstatic, but encouraged when nationally we have started to make the statement that we are moving as a nation towards value-based care, because I think that's what we aim to provide. The RVU, right, the revenue that we generate for an office visit or a social work visit or a genetic counseling visit, you can imagine, is probably not what's keeping the hospital afloat. I will say that getting these patients in so that they stay in care, so that they don't use our emergency room, have urgent surgeries, become heart failure admissions that last too long for the hospital, and extend the hospital length of stay. Those are some of the markers that we have started to look at, similar to many other groups who, accountable care organizations, if you will, who say, if I can keep these patients healthy, it is going to save you and the system money in the long run. And that's been our background argument moving forward. We don't have the numbers for it as well as we'd like to. We've done a lot of studies based on national inpatient databases, just showing how expensive this population is, and they're very expensive. And we've used that general data to say, look, this is the right thing to do. Everyone's moving towards value-based care, and we can keep these patients out of the emergency room. We can keep them in care and make this less expensive. The second part is a little more challenging. It is the advances that can happen in this population. So the surgeries, the imaging, the cardiac catheterizations that these individuals need, by all means we avoid over-testing because, again, the PTSD having too much. But when they do need these things, they're not only things that bring revenue to a hospital, they're actually things that help the hospital grow in terms of their cutting-edge technology, their ability to take something that's not just regular, but a little bit of a Rubik's Cube heart, and now try it. Now use your new technology. And so we have tugged a little bit on the heart money strings rather than just the money strings and said, we think we can save you money by keeping people in care and keeping them healthy. Thus, please support the Health and Wellness Clinic. We think that we need to have patients who do need procedures and are willing to do the cutting-edge procedures, and that's going to make you look good. But there is not money coming. This is them slowly allowing us to add a nurse practitioner, to add a new doctor this year. After 7 years of building this team and showing the value, I think people are changing, but I agree with you. I myself, I'm in the middle of trying to write an essay on value-based care. I've been in the middle of it for about 3 months now, right? Because that, I think, is the issue, is how are we going to define value? And it's challenging. It's challenging. I don't know if that was actually a direct answer, but it's the best I can do, probably.
Thanks so much.
Ami, it sounds like you think the biggest source of value is the avoidance of avoidable acute care episodes. Are there others, perhaps better coordination of care, eliminating duplication of services?
Absolutely. So I think one of the best things that we can do is we can actually centralize their care a little bit. So we like to think of ourselves, I don't use the phrase often, as a medical home, right, a patient-centered medical home for these individuals in helping to coordinate that care. We've actually made a real effort, and I don't know if this helps our hospital specifically. I think it does help the healthcare system and probably helps the insurance company who insures our patients, in that when we go to the referring hospital and we say, please upload to us your ultrasounds, your MRI images, your cath images, and therefore we won't need to repeat probably all or at least half of these. I think probably that is a big savings. It's not necessarily savings here locally if we're not doing the testing. It's most certainly a savings for the patient, the system, and perhaps the insurance companies are a place for us to look for kind of promoting this value-based care, the lack of duplication of care.
I mean, it's been a terrific conversation, and I always regret at this point that we're almost out of time, but I want to give you a chance for one last comment, perhaps what you're most proud of as you think about the journey you've been on over the last several years building your team.
I think the recognition that this kind of care is not and should not be limited to a complex cardiac population is probably the thing that I'm most proud of recently. So I recently took the position, I think I told you, Chris, I'm now the director of outpatient cardiology for all of the Mass General Hospital cardiology groups. And I think in part, well, I hope in part, the reason that I was, selected for the job is that we have this concept of patient-centered care, and it almost pits us against, well, what's the other center, right? Is that provider-centered care? And in our small group, we have learned that patient and provider-centered care are actually the same thing. Everybody wants the same relationship, the same process, things to go smoothly, healthcare to get done without too much testing, and timely interventions when they need to happen. And in the background of all that, everybody just wants people to live good lives. And so I think, in a way, our small group here has maybe touched the rest of the group in showing that patient and provider-centered care can actually be one. And so I hope, looking to the future, because you always ask this last, Chris, I hope, looking to the future, that that concept actually does spread throughout cardiology here at our institution, and hopefully in other disciplines as well. I think if we all think about it that way, then we're probably going to eventually head in the right direction with healthcare.